Today I want to talk about the drugs for diabetes mellitus, and in this particular unit on hormonal agents, we're going to concentrate on the drugs for diabetes. There are some new insulins that I want to cover. This particular chapter has quite a bit about the pathophysiology at first about diabetes, and we're going to go through this relatively quickly. Diabetes certainly is, the definition of diabetes is characterized by chronic hyperglycemia due to problems with insulin secretion, like with the type 1 or like the type 2, not enough insulin. And the effectiveness of endogenous insulin can be a problem. There might be resistance to the action of insulin. It's not maybe the receptors are not sensitive to the insulin, and so the insulin isn't getting into the cell to take care of the glucose. And essentially, when we talk about it, you've got the high blood glucose is characterized by consistent management. You try to get it within normal range, which is 70 to 120, and that's the goal of treatment. But you also have, both in the type 1 and type 2, the 3 Ps, polyuria, polydipsia. One that isn't on the slide is polyphagia. And, of course, weight loss and ketones in the urine. According to the National Center for Health Statistics, 12.6% of adults 20 years of older have diabetes, and many more persons probably do have diabetes that are overweight but just haven't been diagnosed. So the 9.6% is an estimate. 20% of this population that we know have diabetes take insulin, and most take multiple medications, 5.2. So again, you see the polypharmacy with this population as well. And so we have to be aware of the fact that they take many medications. They might take insulin as well as an oral hypoglycemic agent, and they may take a lipidemic agent, maybe other endocrine types of medication as well. The type 1 diabetes is considered an autoimmune disorder characterized by beta cell destruction. It has the genetic component so that individuals have these islet cell antibodies, and the typical onset is before the age of 30, and the genetics play a large part. These persons are genetically susceptible. The type 2, which is the most prevalent form, is often due to the development of resistance to endogenous insulin, and frequently occurs in persons, again, with the family disposition, people who are overweight and over the age of 40. And you see a lot of other types of problems in the type 2, physical inactivity, high triglycerides over 250 milligrams, and hypertension. And you see that with the insulin resistance. And you might, other causes of diabetes, you might have a person with pancreatitis or Cushing's syndrome, and you might have a person that is using temporarily, has a person with hyperglycemia who's using glucocorticoids. Diabetic insulin resistance is characterized by the fact that the person is using more and more insulin to take care of their problem, and that's the hallmark of that. They're taking their insulin, but it's impaired ability of the insulin to lower the blood sugar. And the severe resistance is when the client needs 200 or more of insulin per day. The extreme is when they need 300 or more units per day. And it shows you the picture there of I always think of insulin as the key to unlock the cell. And so here you have the key unlocking the cell in type 1. There's not enough insulin, and you have the younger person there, type 2, and sometimes very older persons, certainly the older age group, and then the insulin is not getting through the receptors. They're not sensitive enough, and or there's not enough of them, and the glucose is not getting into the cell to act properly. There's many complications of diabetes, certainly hyperglycemia, ketoacidosis, and insulin, what we call insulin reaction or hypoglycemia, that you need to watch the patient for. And then the long-term effects, many of them, heart disease, which is the leading cause of death with diabetes. 3 out of 4 diabetic-related deaths are caused by heart disease and blood vessel disease. And diabetics are 2 to 4 times more likely to have heart disease than persons without diabetes. And type 2, who don't have heart disease, may have increased risk of a heart attack. Many factors, high blood pressure and atherosclerosis, also contribute to that. And then you've got hypertension, stroke, certainly hyperglycemia, altered lipid metabolism, retinopathy that can lead to blindness, and you've got nephropathy, which can lead to renal failure. The high blood glucose levels can damage the kidney. Even when the medication and diet are able to manage the diabetes, it can lead to nephropathy and kidney failure. And then you have neuropathy, especially that can lead to feet infections. A person steps on a pin or an object and injures their foot, and then they can't feel that it's in there. I had a patient one time that stepped on a paperclip at home and then could not feel that it was in there, and had to have the foot amputated. And so foot ulcers, foot problems as a result of the neuropathy often lead to amputation. And so diabetic persons need to take very good care of their feet. Also, erectile dysfunction, and the wheel shows you a lot of the complications there. Diabetes and pregnancy, you'll hear more of that in your maternal child course, but gestational diabetics, we see quite a few in the clinics, and that's the diabetic that appears in the pregnant person, and they have the diabetes while they are pregnant, and the blood glucose is monitored along with diet and medication, and a lot of times they're on metformin. But essentially, they when they're no longer pregnant, the diabetic state disappears almost immediately after delivery, and so they need to be monitored during their pregnancy, and especially if they have a pre-existing condition of diabetes. And it can cause damage to the fetus, so we want to be watching them for that. So you can read the slides here. I'm not going to go into a great deal about gestational diabetes. Hemoglobin A1C is a boon to us in that we are able to look at it, and it's the best indicator of the average blood glucose level for the past 120 days, and it assists us in the evaluation and treatment of patients with diabetes. And frequently it does help us to manage, like the gestational diabetic is a test that it estimates their glycemic control, and it's a good way of diagnosing diabetes as well. Then other tests that we have is the fasting blood glucose test. We ensure that the patient has fasted no food or drink other than water for the last 8 hours prior to the blood draw. And anti-diabetic medications, and that's frequently you do have questions on the NCLEX that will ask you their NPO, they've been surgery, and they take insulin, or they would not take their oral hypoglycemic agent. Usually that's postponed, and once they get there, maybe the blood is drawn, and the doctor orders that, and you check them, and then you call the physician with the blood results to see what they want to do. The same way with the insulin. You usually call, they might give a little bit of insulin, especially if it's a later surgery or a later procedure, and so that you want to, they might give because they will do better in surgery if the glucose is taken care of. And so you do want to call the primary care provider for that. And then the oral glucose tolerance test, you instruct the client to consume the balanced diet for 3 days prior to the test, and then you instruct them to fast like 10 to 12 hours prior to the test, and a fasting blood glucose is drawn at the start of the test, and then they take a specific amount of glucose, and then the blood glucoses are drawn every 30 minutes for 2 hours, and they're assessed for hypoglycemia throughout the procedure. And then the casual glucose test, that's the one prior to meals. We do that often on the units, and the target is 90 to 130 milligrams, but we are looking more at borderline diabetics and trying to counsel people who are over 100, and so that we want to be sure to be cognizant of that in terms of prevention. And because, as you saw, there's so many complications with diabetes, and you for the test you want to follow their samples. You do it before meals, and usually at bedtime, and the patient does it at home. It shows you, I have a couple of pictures that shows you the hemoglobin A1C, that the glucose attaches to the hemoglobin to form the glycosylated hemoglobin A1C, and it has the lifespan of 120 days. Then it shows you the table there in terms of what you want to achieve, and of course the 7 is a good reading. Talks about the pre-diabetes and the counseling that you want to give in terms of the patient who's at risk for developing type 2 diabetes, and that exercise and watching their diet, reducing their carbohydrates is patient teaching that you want to do. And basically the primary goal is to prevent those long-term complications, and tight blood glucose is important. Controlling the blood pressure, controlling the blood lipids is also important. It shows you the signs of diabetes, fatigue, irritability, blurred vision, frequent urination, and that interrupts sleep too. Sometimes when you're taking the history, the patient will tell you, I'm not sleeping, I'm getting up all the time to urinate at night, and especially the older person will check their blood glucose. Extreme hunger, extreme thirst, and unexplained weight loss. Frequency of infections, you want to look at that too, and that's not